welcome them as they get here, but we appreciate your coming. My name's Doug Miller, and I am the Dean of the Medical School here at New York Medical College and a card-carrying cardiologist, and happy to be welcoming you here on behalf of both the American Heart Association chapter and the New York Medical College to our program. We obviously would have wanted to have this in Heart Month, but everybody's schedules were so busy, we pushed it into March, and I guess we've made a new Heart Month out of March, but here we all are, so thank you for extending the season of Women's Heart Month. We have obviously two excellent speakers, which I'll introduce. I'll introduce them both very shortly, but both of whom are known to be widely written and very expert in the field of heart disease and women's heart disease. So we're very excited to have them both here today. As I'm sure you saw at the back of the room, there are some materials here from our American Heart Association colleagues. There's a very large fridge sticker magnet thing here with a picture of the Heart Walk child, an honoree, and we were part of the Heart Walk with many of you. I hope were there as well in the fall, and it was nice to see us honor this family and this little guy here on this magnet who had heart surgery done at an early age and was healthy and looking well. Also, there's a save the date for the Westchester Fairfield Gopher Red Women Luncheon on the 2nd of June coming up in the near future. And there's information back there if you wanted to grab that and be part of that. As I was extensively preparing for today's talk, which my role is just to introduce people, so it was not extensive, I did come across this little brochure in an American College of Cardiology mail-out that comes every month, and it talks about cardiovascular disease is still the #1 killer of adults, and it talks about all the things that are happening in terms of work towards helping reduce the death rate from cardiovascular disease. But I think the one thing that's probably not lost on any of you is that it's the #1 killer of women and men, and it's something that has been long under-recognized and perhaps underappreciated, but now is well understood by cardiologists and physicians in general, that women really do have a high risk of heart disease and are dying from heart disease on a regular basis. I published a paper many years ago now about the risk of heart disease in women that was widely circulated and kind of became known a little bit in the field, and was actually the first male member of the American Medical Women's Association, which is, I think, an honor. But you know, it's been 25 years since that paper was published, and we still are dealing with the issues that relate to women and their risk of heart disease being recognized at the same rate as men. And of course, all the people pictured in this booklet are men, just so you know, so I confirm my hypothesis that this is still thought of as a male disease. Our two speakers today will help us all understand a little better where we are with our understanding currently of heart disease in women, what the risks are, what the differences are between men and women and their risk of heart disease, and what we can do to reduce the risk of heart disease in women and treat them more effectively as we go forward for the next 20-25 years. So we're excited to have two experts in the field here. Dr. Duda is one of my colleagues who works at Westchester with me and a member of the Division of Cardiology. She's an assistant professor of medicine at New York Medical College and the director of the echocardiography laboratory over at our medical practice site. She's extensively trained as a non-invasive cardiologist with interests in nuclear imaging, echocardiography, and cardiac CT imaging. She graduated from a small college called Harvard with a magna cum laude degree, and received a medical degree from Cornell, another pretty fair place, and did her internal medicine residency at New York Presbyterian Hospital, and received teaching awards as a resident in that training. She had her cardiology fellowship at Montefiore Medical Center and a fellowship in cardiac MR and CT at St. Francis Hospital. So she's really, really well trained and board certified in internal medicine, cardiology, nuclear cardiology, echocardiography, and cardiac CT. She's authored a number of studies and papers in the medical literature, including journals such as the American Journal of Cardiology. And we're very pleased to have her here today speaking to us as our keynote speaker on the topic that she'll be heart disease in women, what every woman needs to know. So, Tanya, please come forward and we'll welcome you.
very much. I'm so excited to be here, and I'm excited to see so many people here after a snowstorm last week. And I told everyone I could think of not to shovel, just so you didn't come to the hospital afterwards. So,
Slide's not advancing?
My slide's advancing on here, but I don't see it moving up here.
That's just.
No, no problem. It's usually me, so.
There you go.
Perfect. Thank you. So, what every woman needs to know, and as Dr. Miller already spoke about, heart disease affects women just as much as it affects men. So it's very important to know a little bit about the risk factors and how we can modify them. So I'll focus on women to start, and it kind of started with the Nurses' Health Study. So prior to this, there was a large study called the Physicians' Health Study, and at that time, most physicians were men. So there was a lot of studying about risk factors for heart disease in men. And all of a sudden, somebody in 1976 said, hey, wait, we have a large group of women we can study as well, and we're going to call it the Nurses' Health Study. So over time, 12,000 female nurses ages 30 to 55 were followed, and every 2 years they were sent a questionnaire about their overall health, their diet, had they had any hospitalizations, what diseases had occurred over time. And as you can see here, they were followed, they were followed at a fairly young age, 30 to 55. And every 2 years, they were looked at in terms of the incidence of coronary disease over groups. And you can see when they're divided up through the different ages, that as you get older, the incidence of coronary heart disease goes up. But interestingly, over time, you'll see that there was a sharp drop as there became more recognition of some of the risk factors associated with coronary heart disease. So women's awareness of coronary disease used to be, I think, much less than before. Because in the past, women themselves were not so aware that they were at risk for developing heart disease. However, through the efforts of the American Heart Association, the Go Red for Women campaign, there's been a greater emphasis in spreading the word that women can get heart disease too. And in this study, you'll see that the top slide is what the actual leading causes of death for women were, and the bottom slide is what women thought they would get, and what diseases they thought they would develop. And a lot of the awareness of breast cancer was due to the Pink Ribbon campaign, and it's a campaign we tried to emulate for other diseases to spread awareness. So the prevalence of heart disease in men and women goes up as you get older, and this is a study that shows that it's actually fairly even over time. What I always like to point out in this slide is it's not zero if you're less than 40. There is evidence of heart disease in people between the ages of 20 and 40 as well. Although obviously the rate goes up as you get older. So what is cardiovascular disease and what particular diseases are we worried about? So that gets broken down into multiple different diseases. One is coronary heart disease, which we think of as plaque in the blood vessels of the heart, diseases that give you heart attacks. But it also talks about stroke, heart failure, high blood pressure, and diseases of the arteries in the body. However, in terms of percentage of breakdown of deaths from cardiovascular disease, we tend to focus on the heart because that's where we get the most bang for our buck. We can make the most strides in terms of decreasing the number of deaths. And you will see that we have made some strides. So these are deaths attributable to cardiovascular disease starting in 1900, and you'll see that it actually peaked and has started to come down over the past 2 decades. If we narrow that time range down from 1979 to 2014, you'll see again that there are significant strides in both men and women in terms of decreasing the rate of death from cardiovascular disease. And part of that is not because we're decreasing the disease, but our treatment for the disease has gotten better over time, so we're able to prevent death better than we used to be. However, what can we do to prevent the development of coronary artery disease in the first place, which would be, of course, the best thing to do, so that we don't even have to worry about how we're going to manage the disease once we get it. And in 2011, the American Heart Association put out an update specifically for the prevention of coronary artery disease in women. And it's, of course, a very busy slide, but I circled 2 things. And one of them is that at the very top, which you can't see, is evaluation of cardiovascular risk. So of course, we talk about symptoms, we talk about depression screening and blood tests, but one of the most important things that was added in 2011 is a pregnancy complication history. Now, when a cardiologist typically sees a woman in their office, they tend to be on the older side, long past their pregnancies, and we have to kind of dig towards that data. And the reason we do that is a few studies had come out prior to 2011 showing that if you had preeclampsia or gestational hypertension or gestational diabetes, your risk of developing coronary artery disease 20, 30 years in the future was higher than women who didn't have those diseases. And you can imagine that we tend not to really ask about that. I mean, it occurred 30, 40 years ago. We ask how many pregnancies did you have, and then we move on from that. But that actually plays a significant role in your evaluation of risk as we move on in time. We started at Westchester trying to catch women at the early stage. So once they had preeclampsia and delivered in the hospital, we actually started talking to them about the risk of coronary disease in the future, and to try to remember that in the future they should bring that up, that they do have a risk factor that was not recognized previously. The other things we talk about are implementing lifestyle changes, following a diet, regular physical activity, and weight management. And that's what I'm going to focus on today in terms of prevention, because that's what most of the update in 2011 was about. So I like to call it the don'ts, it doesn't help, and the do's, which of course is the hardest. It's much easier to avoid something. So the don'ts. So early on, hormone replacement therapy was thought to be preventive in terms of the development of heart disease, because women tend to have higher rates of heart disease after menopause. So we all assumed that if you added hormone replacement therapy back, you'd have a lower risk of heart disease. It made sense, and everyone thought that that would work out. However, when it was actually studied, meaning people were given hormone replacement therapy and a separate group of people weren't, turns out the rates of heart disease and blood clots go up when you get hormone replacement therapy. So it's very much not a treatment for heart disease. And in fact, if you do take hormone replacement therapy, we follow it very closely to make sure that you're not at significant risk for developing clots or heart disease. And I would say that most gynecologists are now so aware. I've seen several patients who are sent to me just to see if they can go on hormone replacement therapy and how would that do with their overall cardiac risk. But that's been a big change over time. The second is there was a large study on antioxidant supplements, vitamin E, C, and beta-carotene. And the results of the study were that they should not be used to prevent primary or secondary, meaning that it doesn't prevent the development of heart disease and it doesn't help you once you have heart disease. It's not that it hurts you, it's just that it didn't seem to help. And when you see a cardiologist who are already taking so many pills, we try to decrease the number of pills you overall take. So what are some of the do's? So essentially it breaks down into 7 factors. Okay, a healthy diet, and things that everybody knows: physical activity, smoking, keeping your weight down, watching your cholesterol, your blood pressure, and your blood sugar. And this is actually what the Heart Association has out to try to teach kids all those things. I don't actually recognize some of those icons exactly, so I can't tell you which icon goes to which, but it's to try to tell the kids that there's life's simple 7, and there are 7 things you should focus on as you go forward. So what is a healthy DASH life diet? So it's fruits and vegetables, it's high fiber foods, oily fish at least twice weekly. Okay? You shouldn't avoid, you want to avoid cholesterol, salt, sugar, trans fats, things that make food taste pretty good. Alcohol is always a little bit questionable. Many studies show that there is some benefit to the consumption of 1 alcoholic drink for men a day. And that does not mean you could have 7 drinks in 1 day, and I always have to give that caveat. It really means 1 drink a day. The benefits are not so apparent for women. It's believed that that may be too much for women. As a result, I usually tell people that you shouldn't really go above 3 drinks a week for women. These women tend to have smaller body sizes, and the metabolism of the alcohol doesn't seem to be as effective as it is in men. So we are doing better over time, and this is age-adjusted trends in major food groups. So we've switched over from high-fat dairy to low-fat dairy through 1990. We've cut our intake of red meat, and we've been eating more white meat, just like all the advertising has been telling us to do. However, these are the actual healthy diet targets that the American Heart Association wants us to get. So the green on top is the ideal. Like 80% of the time you eat those fruits, vegetables, and you avoid salt and sugar. Intermediate is like half the time, 50% you're hitting those goals, and poor is less than 40% of the time are you hitting anything like that. And you'll see that really, over every year, we're doing a little bit better, but we're hitting very little of the green. It is one of the hardest tasks because it's every day, it's every meal, and it's something you have to think about all the time. And I tell people, in some ways, this is almost the hardest of the goals to achieve because it is constantly something you have to work on. But we are doing a little better. We went from 0.7 to 1.5%, I think. So it's almost doubling. So, but food and advice can change behavior. So this was one study where they took a group of people and they said, you know, we really want you to eat much healthier food, but we're going to advise you. And they gave them a line to call into, and they kind of met with them once a week and said, this is what we want you to eat, kind of like meeting with a nutritionist. They also said, well, what happens if we just give you the healthy food? Are you going to eat more healthy, or are you going to eat something else? And what they found, of course, is that you do much better if we do both. So if somebody advises you and we provide you the healthy food so you don't have to go search for it, you hit those goals much better in terms of the number of servings of fruit and vegetables and whole grains you're supposed to have. But that is hard to implement, as you can imagine, for a lifetime. So physical activity. Goal for adults, everyone always wants to know how much exercise do you need to do, and it all depends on what kind of exercise are you doing. So this is what I usually tell people to do. You need to do 30 minutes 5 days a week because this is the type of exercise that most people do. It's the type of exercise I do. Walking, easy jogging, dancing, doubles tennis, something you can talk during, something not too strenuous. But if you do this, you need to do a lot of it because you're supposed to hit 150 minutes a week. However, if you are much more intensive and you actually run and you do lap swimming and aerobic dancing and singles tennis, or a much more competitive sport, you only need to do 25 minutes. So you can cut it in half essentially, and only 3 times a week. Okay, so the intensity of exercise matters in terms of how much you actually need to do. So again, if you look at men versus women, we're actually pretty even with hitting the exercise targets, but the younger group does better. I think we've gotten the word out better to the group 18 to 44, and as time goes on, we hit those targets less. So that is something to keep in mind. This is beneficial at whatever age you're at. The trends in eating have improved over the years, just over the past few. So there's some muscle strengthening guidelines too, but I tend to focus on the aerobic guidelines. And that's the top line. So in adults over 18 over time, through 2015, we've done better with spreading the word that you need to move. So the problem is if you're looking for weight loss, you need more exercise. Because that degree is great for your heart, but you're not going to lose weight necessarily with that. So you need to do 60 to 90 minutes daily of moderate intensity exercise if you really want to achieve weight loss through exercise. And if you want even better heart health, more seems to be better in this case. So abstinence from smoking. So I tell people that is really the #1 thing that you should do. It comes up on the list a little bit lower down, but that is vital because almost everything else you do matters less if you're still smoking. So this is a picture of a patient who had no risk factors, and this is a coronary angiogram. So you can see here it's the same blood vessel. That's a smoker, that's a non-smoker, and it should look like that with the contrast dye spreading through the blood vessel, a nice even, but you see here that no contrast goes through because she's developed plaque at that site just from smoking, and they're actually the same age. I found 2 pictures of 2 women the same age. One was a smoker, one wasn't. So you absolutely have to quit smoking. So we're doing better. So these are the rates of smoking. It's very much geographic, as you can tell, through the map. And New York is actually not so bad with the rate of smoking compared to other areas. Dark blue is the worst. Okay, and you can see that the Southern Atlantic states don't do so well with making sure that smoking is not allowed in most places. We have done better over time as well. So this is the prevalence of smoking in women and the use of postmenopausal hormones, which we obviously stopped after 92. But the smoking rates have gone down over time. So weight is a very important factor as well in your overall health. And ideal weight is a funny thing. We define it in many ways. Sometimes we tell people your waist size should be below 35, but the problem is everyone's a different size, a different height. So we came up with this equation called the body mass index. You don't even need to know the equation because the NIH has a calculator on it, where if you just put in your weight and your height, it will tell you what your body mass index is. And essentially we've told people that 18.5 to 25 is normal, and if you're over 30 on that index, you're hitting obesity rates. So the prevalence of obesity in women is slightly higher than men, in those over 25 years of age. And the rates kind of fluctuate over the ages. It covers every age group, whether you're 20 and over, or whether you're 60 and over. So it is something that we need to work on at every age. Obesity is also very much geographically distributed. I will tell you that, I don't know if you can see it on the screen, but no state is at less than 20%, even California. They have the 20 to 25% rate of obesity, but nobody has hit the less than 20% target. And New York is in the yellow, the 25 to 30% target. So your total cholesterol. So now we're getting to things that your doctor has to help you measure. So all of those things you can kind of figure out on your own. And the last three, you need to visit someone to figure it out. So your total cholesterol should be less than 200. So I actually hate that line, because your total is a composition of your good and your bad. So if your good is really high, you could have a total cholesterol that's elevated, and that doesn't really tell you anything. So what you need to know is your total numbers divided up. So your LDL is the lousy cholesterol, that's the bad cholesterol, and that number you want as low as possible. That's what we give all these statin medications to do, actually, is to lower that number. Your HDL is the happy cholesterol, that's the good cholesterol. The higher, the lower risk over time that you have of developing heart disease. And the triglycerides are essentially fat that you've taken in, a lot of carbohydrates that you've taken in. And so I tell people, sometimes I measure their cholesterol when they're not fasting just to show them what the triglycerides look like. And when they come back very high, we measure them again fasting, and it's amazing how different they can be based on what you've eaten for the past meal. And lastly, your blood pressure and your blood sugar. So ideal blood pressure is less than 125 over 80 without any medication. And your ideal fasting blood sugar is less than 100. So in terms of the prevalence of high blood pressure, that is something that goes up with age, okay? Because your blood vessels do get calcified over time. But you'll see that even people in their 20s and 30s, there's a rate of high blood pressure there. And some of that is related to diet, related to obesity, and some of it is related to genetics. But the lower we can get that number, the better. When you get to over 75, you'll see that almost 80% of the female population has high blood pressure, so it's not so unusual. At that point, the most important thing is to use medication to bring the blood pressure down to normal. Diabetes is one of the toughest parts of the 7. So this is a graph, I didn't even go into treatment. This is a graph of how many people don't even know that they have diabetes and therefore are not treated. And that's the purple. So you're hitting almost a quarter of the population doesn't realize that they have diabetes. You wouldn't know because it requires a blood test. And there's no thing at the pharmacy where you could stick your hand in and check that. You have to go somewhere to get that tested. So that is one of the hardest parts about diabetes, is first finding if you have it. The second group is you're not treated, but you're aware. That's actually 10% of the population. And then the last group, that is the massive red, is you know you're being treated, but you're not controlled. And that speaks to how difficult diabetes is to control, because it's a combination of all of the factors. What you eat, how much you exercise, and the medications you take. And all three have to be at the ideal to get your sugar under control. So where are we now? So these are, I believe, 2016 data that were just published in January. And it kind of goes through the 20 through 49 population and over 50 in terms of the green is great, the red is terrible. Okay, so in terms of smoking, we're pretty good actually. In terms of body mass index, we're about 50-50 at trying to achieve the right goal. Physical activity, we could definitely do better in the over 50 crowd, because you'll see that there's very little green and there's a lot of red. The healthy diet score, we barely see any green. So we could do a lot better there. The total cholesterol, because of medical therapy, I think is not so bad. And the blood pressure and the diabetes, we have under control. But if you look at the things that we don't hit the goals on are actually the things that don't require a physician or a nurse or any kind of equipment. It's physical activity, body mass index, and your healthy diet, all things that we can manage on our own. It really does matter. So this is the incidence of cardiovascular disease according to the number of factors and behaviors. So remember, there were 7 things, so some of those are factors, like your blood pressure, and some of those are behaviors, like do you smoke? So if you have 0, you haven't hit any ideal on either end, all 7 of them are in the red territory, you're hitting an incidence of almost 35% of developing cardiovascular disease, or having it. Versus if you've hit all of the ideal behaviors and risk factors, you see that you're almost at the 5. Okay, it makes a big difference in terms of these 7 factors. Your estimated 10-year risk, if you're in your 50s, or between the ages of 50 and 54, actually goes up enormously based on how many of these factors you have control. So here they don't even talk about exercise, they just talk about things we measure. So your cholesterol, your blood pressure, do you smoke, and do you have diabetes? And if you have none of those things, that's A. Again, it's not 0. There is a risk of cardiovascular disease developing in people who have ideal risk factors, but it is much lower. It's 7.9 for men and 4.5 for women in Group A, versus Group D, where you have all of those things, and you're still the same age. In 10 years, you have almost a 30% chance of developing heart disease. So another way to look at it is if you're a 55-year-old woman with no risk factors, through the age of 80, you have about a 6.5% of a risk of death from coronary artery disease. Now that's 25 years down the road. But if you're a 55-year-old woman with only 2 risk factors, that could just be high blood pressure and you smoke, you have almost a 20% risk of death through the age of 80 from cardiovascular disease. And those risk factors that they measured here, again, just cholesterol, blood pressure, no smoking, no diabetes, they didn't even talk about exercise or a healthy diet. And this is the graph that they published several years ago. I always use this because I think this is the best way to show that every risk factor you control really does matter. So the top is 2 or greater of those 4 risk factors, okay, and the lifetime risk of dying from coronary disease. The green is all your risk factors are optimal. And if you have 1 risk factor not optimal, you're doing well. But as soon as you start hitting 1 elevated risk factor, your blood pressure's out of control, the risk of developing heart disease or dying from heart disease goes up extensively. So I just put that slide back because of the 7. And like I said, most of the 7 are under our control. So everything we can do for these 7 factors makes a huge difference going forward.
Very good, very good. Thank you.